Top-Bed Talk.
I'm Dave Yates, a consultant anaesthetist up in York.
I'm Rachel Barlow and I'm a clinical lead for Prehab in Wales.
So we will crack straight on with Mr. James Hernon, who is a consultant colorectal surgeon from Norfolk and Norwich and is going to tell us about the Prepare ABC trial.
Thank you very much for the invite to discuss Prepare ABC, our NIHR funded randomised controlled trial looking at supportive exercise programs for accelerating recovery after a major abdominal surgery. So we first thought of the idea in 2013, so a long time ago. So it takes a long time to get these studies up and running. And it was at a surgical sandpit meeting where we tried to set what important questions existed within the colorectal community. And there were three, and the top one and the bottom one could quite easily have fitted into an anaesthetic meeting, so looking at frailty. And the one I was involved in was looking at pre- and post-operative exercise programs to reduce complications following colorectal cancer surgery. And we thought the main aims of Prepare ABC should really be to establish the effectiveness and cost-effectiveness of hospital and home-based pre- and post-exercise, pre- and post-discharge exercise programs, and looking at both short and long-term recovery. So we devised a three-arm, multi-center, randomized controlled trial, picking up colorectal cancer patients at the point of diagnosis. Those who go off and have rectal cancer long-course chemotherapy, of which it probably represents about 10% of our patient population, get invited to the study once we know they've still got a curative resection. And we try to be as inclusive as possible. Patients ASA 1 to 3, and if you're having an elective resection with curative intent. And that's about 90% of our patient population group. Exclusion criteria are really those which would probably prevent a elective resection, so unstable cardiovascular complications and concurrent medical conditions stopping exercise. And at baseline, if centres are able to offer it, we have a look at their cardiopulmonary fitness using a CPET test, and then an assessment of their quality of life, their HAD scores, physical activity levels, how good they are at exercising, and an idea of their grip strength. And then those patients in the hospital and home-based arm are invited up for a 45-minute pre-intervention counselling session using behavioural modification techniques to try and make them aware of the importance of exercise, the consequence of inactivity, how to goal set, and practical advice re-exercise, and also given motivational literature and a pedometer and exercise along, which are also really pokes to get them carrying on with their exercise regimes. And then those in the hospital-based arm are invited up to the hospital where they undergo a supervised session. And we try to get in at least 6 sessions in the 2 to 4 weeks before their operation, so 12 possible, most will fall around 6. And we exercise them at 60 to 80% of their heart rate reserve, 5 minutes at that level, a 2.5-minute active rest, and up to 6 sessions, up to 6 intervals if they possibly can. Those in the home-based arm still have contact with us. They get given an exercise prescription to achieve at least the Chief Medical Officer's recommendations of 150 minutes with 2 resistance sessions. And they're also given a phone call every week for 15 minutes just to highlight the importance of exercise and address any issues they're having. And those in the standard care arm just get whatever standard care is within the trust. They undergo a post-intervention cardiopulmonary exercise test and then go on to have their colorectal resection. And it can be done either open or laparoscopic. Currently, the split's about 70% nationally are done laparoscopically, 30% open. So we've included both arms, both operations in the study. And then on discharge, patients are assessed for their in-hospital morbidity, length of stay, and also the point at which they're fit for discharge, appreciating that depending on the discharge destination of patients, the length of those times will differ. And then we assess our first important outcome, our 30-day post-operative morbidity using Clavien-Dindo classification. And at 6 weeks, patients are then re-invited to join the study. Those in the hospital-based arm are invited up once a month to the hospital for supervised exercise, but signposted to exercise facilities in their area. The home-based arm get a monthly phone call to encourage exercise and intervention, and standard care is whatever is offered in the trust. And around the country, it's very, very little. There's very little post-operative rehabilitation afterwards. And patients are followed up for a period and are exercised and followed up for a period of 12 months post-randomization. And we assess at 6 and 12 months their quality of life, and the same measures we looked at preoperatively. In terms of the study endpoints, two primary outcomes: short-term 30-day postoperative morbidity and health-related quality of life at 1 year. And then a whole host of secondary endpoints which really look at the whole pathway from the preoperative to the post-discharge and 1 and 12 months. There's a cost-effectiveness analysis running through the whole study. So June will be happy. In her talk earlier on, she thought cost-effectiveness was an important measure, and we built that into our study. And also a process evaluation. There are lots of sites doing it, and we wanted to be clear that sites were doing the intervention as anticipated. So our research team have been going out, looking at sites that are involved and seeing how they're running the study. And we also have an internal pilot running for the first year, which we've completed, and I'll just go through quickly to show where we've got to so far. And the internal pilot, I'll come to in a moment. In terms of our sample size, it's based on the two outcomes, 30-day post-operative morbidity. The literature and our own experience suggests 55% of patients will have some sort of post-operative complication, at least one or more on the Clavien-Dinder classification. And at 90% power to see a 25% reduction, we need 346 in each arm. We expect about a 10% dropout by 30 days. So it results in a big number, 1,146 patients. We need less for the health-related quality of life at 1 year, 795. So the internal pilot was not to look at effectiveness or efficacy of the investigation, but just to look at whether we could reassure the NIHR funder that we could deliver the intervention in the suggested time frame. And the targets we had to achieve were to set 10 sites up, recruit about 30% of eligible patients, 50% of sites able to recruit at the end of the year to sustain the study, and 70% of patients adhering to 50% of the sessions. So it started in November 2016, ended in 2017, the internal pilot. The main study continues. And with site setup, we did fine. We set up 13 sites within the first year, but the majority, as you see, came on board within the last few months of the study. So it takes a long time to set sites up. And our range was anywhere between 12 to 14 months, so a median of 8 months to set a site up. And it just ended, and the reasons were that there were issues at sites, and it was all based around costs. So staff to deliver the intervention, facilities to deliver the intervention, and exercise bikes and CPAP equipment, all based around cost. So it takes a long time to set sites up. In terms of eligible patients, we were asked to recruit approximately 30% of eligible patients. So we screened in that first year 877, and we recruited 135. But not all were eligible. And then when you break it down into eligible and ineligible, we end up with a range of either 44 or 24% of patients, of eligible patients being recruited. And the reason for that is the other group. Sites were given the choice to take other in terms of eligibility. So if you assume all others were actually eligible, it's a 24% recruitment. If they weren't eligible, it's 44. I think in reality, once we've drilled down the data and we've cleaned it up, we'll be close to 30%. And what were the reasons for non-recruitment in that first year? There were 4 main themes. There was operation date. If you give a patient an operation date within a week or 2 of their attendance, they'll not want to participate. They'll say they have no time. Although some of them are retired, they're busier than they've ever been, so they have no time to come up to the hospital. They can't travel up to the hospital, or some patients have no interest in exercise. In terms of recruitment rate, I'll spin through it because I appreciate I'll be running close to time. On average, we recruit 1 patient per month per centre. Some do slightly better, some do slightly worse. And that sort of recruitment rate's also been seen as the study's gone on. In terms of adherence, the majority of patients do more than 6 sessions, and 70% of our patients do at least 6 sessions or more, so achieving the threshold we wanted to achieve. In terms of the adherence to the home exercise group, we considered adherence in that area of patients who received at least 2 or more phone calls, and we were again 85% there, so well above the threshold we wanted with adherence. In terms of adverse events, it's important in a study to show that you're picking up adverse events. It shows that it's been robustly run. And about 18% of patients will have some sort of a event, and 10% in our study was related to the exercise intervention. But they were minor, they weren't significant: knee pain, leg pain, bottom pain, and dizziness from being on the bike, so all minor complications. And in terms of complications, we were powered based on a 55% complication rate. We've seen 54, so we're thereabouts. So the internal pilot showed that recruitment was feasible. Patients adhered to the study protocol, and it was safe, but we are behind with our recruitment. So where are we now? We're now 460 patients in, 27 sites open, 24 still recruiting, and we're open to new sites. So a big thank you to all the participating centres.
Nick Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com, and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. EBPOM.org is their website. That's EBPOM.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.